All right, guys. So this is the other half of the assessment video. We're going to talk about neuro assessments really quick. Again, we follow that format: scene assessment, primary assessment, questions. So OPQRST and ample, physical assessment, differentials, and treatment. Neuro is a little bit different. There's a couple really key points we got to get there and it's all about strokes. Strokes are a time-sensitive disease. So when we catch a stroke or when we think we have a stroke, we want to act quickly. Normally in our medical assessments, we ask all these questions, we do the differentials and treatment, and we don't leave scene until we've got all that done. And a lot of times the treatment is carried out on scene. Stroke patients or neuro patients are a little bit different. We want to get these guys moving really quickly. So we do a short assessment on scene, and then when we get in the truck, we run the treatment. Okay, so starting from the top, our scene assessment, we're looking for people who have numbness, complaints of numbness, weakness, dizziness. Maybe they're holding their head, lights are off, and they're kind of covering their eyes, that photophobia or photosensitivity, excuse me. Altered LOC, odd gaits, slumped over, nausea can kind of fit with that neuro one, especially recurrent nausea, and signs of a head injury. All of these things are going to fit in that scene assessment. Moving our primary ABCs, nothing really changes here from the neuro perspective, unless they're unresponsive, and then we might have some difficulty. Some of these neuro patients can get some trismus, and their jaw locks down, can make it hard to manage an airway. Moving down to the questions. So OPQRST evaluating the chief complaint. This is where things start to get different. If you have a patient who has some kind of a neuro complaint, so numbness, weakness, blurred vision, problems hearing or speaking, a headache, recurrent nausea, anything that makes you feel neuro, you're going to do a Cincinnati stroke scale. You'll also hear it called the FAST exam. So you're going to do facial droop. Do they have symmetrical face when they smile? Or is it droop to one side? Do they have slurred speech? So ask them to say the phrase, "You can't teach an old dog new tricks." If it makes sense and is clear, perfect. If not, they failed. And then ask them to hold both arms, palm up, and close their eyes. Oftentimes, my arms aren't long enough. You'll see the arms kind of rotate inward and drift, if they can even lift them. Normal hands should be able to hold up. Cool. If they're fast, so negative, so Cincinnati negative in any of those topics, we're going to do our rapid assessment. So just OPQRST, those letters, onset, provoke, you get it, and ample. We're going to do a very quick head to toe, not getting into too detailed stuff. A quick kind of thought about differentials while we're loading them to the truck. To make it even faster, you can actually tell your partner as soon as they're fast negative or positive for the test, whatever you want to say it. Partner, stop what you're doing. Go get the stretcher. We got to get moving. So that fits, obviously, the pre-hospital world. If you're in a hospital or can't transport, we got to get them moving quickly. All right, so let's say, for argument's sake, they're not having a stroke. They don't meet the FAST criteria. Excellent. So now we're going to hang on scene. So these might be our seizures, our migraine, those kind of patients. Chief complaint, we're looking again, headaches, numbness, tingling, dizziness, difficulty speaking, memory lapses, all of these fit in. We're going to be moving to the medical history, so ample. We're looking for risk factors. So stroke risk factors are very, very similar to cardiac risk factors: smoking, age, diet, exercise. You can also add in history of neurological injuries or issues like TIAs, mini strokes, or previous brain injuries, previous problems with your nerves, numbness. So in that history, make sure you ask about previous neurological history. Cool. We can also, again, hit your previous condition. So we're looking for things like seizure disorders, strokes, brain cancer, tumors is obviously a great one to ask about. ALS are those neurogenic conditions that cause ascending or descending paralysis or difficult movement. Awesome. History of migraines is super important. If they're having a headache, ask about a history of migraines. Awesome. So now we're down to head to toe assessment. Starting at the head. This is worth it where you look up, if you can do it quickly, so that not stroke patient, doing a cranial nerve exam. It'll tell you a lot about their neurological function. I got another video on that. Working down, numbness, tingling, anywhere at all, checking the face, slurred speech, looking at the pupils, make sure their pupils respond to light equally and they're not drifting one way or the other, have nystagmus. Get them to describe the headache. Where is the headache located? That can tell you a lot about different types of headaches. Chest, lungs outs, all those good pieces. AFibers are prone to having strokes, so keep an eye on that one. If you hear like an irregular heartbeat, or they tell you a history of AFib, or you catch it in your vitals, that's something you could think about. Abdomen, the pelvis, looking for incontinence, big one for neuro patients. And extremities, grip strength, and not just squeeze the hands, but can you squeeze and relax? So push in and out. Can they push in and pull back, push in, pull back, and then do the same with your legs. We're looking for strength on movement. If possible, get them to walk, see what their gait's like. But again, make sure it's appropriate. Differentials, we're thinking strokes, we're thinking hemorrhagic strokes or brain bleeds. We're thinking seizure disorders or drug overdoses, chronic neuro conditions, cluster headaches, migraines, tension headaches, lots of different headaches. All right, next video, we're going to start talking about pathologies.